Good evening, everyone. Cancer survivorship has become more important in recent years as we make many inroads into treatment, leading our patients to live much longer and much better lives. And therefore, we have to take into account the way they live their lives with quality of life and repercussions of treatment and a cancer diagnosis. Recent evidence suggests that cancer survivors may have an increased risk of cardiovascular disease. The field of cardio-oncology becomes particularly important as the numbers of survivors very happily continues to increase. Dr. Michelle Bloom is with us this evening, and it is with great pleasure that I welcome her to give this conference. She is a nationally recognized advanced heart failure cardiologist and cardio-oncologist, and has been named Director, Cardio-Oncology Program for the NYU Langone System, Site Director for NYU Long Island Cardio-Oncology Program, and Professor of Medicine at NYU Grossman Long Island School of Medicine. At Stony Brook, Dr. Bloom served as the Director of Outpatient Heart Failure and Cardiomyopathy Center and founder of the Stony Brook Cardio-Oncology Program, the first of its kind in Long Island. Within NYU Langone Heart, Dr. Bloom will partner with NYU Perlmutter Cancer Center, along with a team of multidisciplinary specialists to evaluate, manage, and treat patients with cancer at risk for cardiac disease, including those who have developed cardiac disease as a result of cancer therapy and those who are survivors of childhood cancer with unique risk for early and high-risk cardiac disease. Without further delay, welcome Dr. Michelle Bloom. We're so happy to have you this evening to talk about cardio-oncology.
I have a lot of slides for you tonight, and I have a lot of information to go through that I think is really just very important for anyone with cancer or who has survived cancer to know. So without further ado, let's get started. So I titled this talk, Cardiac Care in Patients with Cancer and Survivors, What Patients with Cancer Should Know About Their Heart Throughout the Cancer Journey. So I think before we even start, I'm just going to go with an oldie but a goodie. An ounce of prevention is worth a pound of cure, which of course we know was first stated by Benjamin Franklin. So with this talk, what I hope to do in a very short amount of time with a lot of slides is to make sure that by the end of this talk, you understand the scope of the problem of cancer and heart disease. I want to discuss cardiac care, including how we do surveillance, prevention, follow-up, in specific populations of cancer patients and cancer survivors, like for breast cancer, prostate cancer, and a few others, highlight cardiac considerations in adult survivors of cancer, and also explore the unique considerations in adult survivors of childhood and young adulthood cancer. So some facts about cancer, treatment, and heart disease. Cancer and heart disease account for up to half of the United States deaths every year, and outcomes are actually far worse in patients that have both cardiac disease and cancer. Patients getting treatment of various types for cancer can be at risk of many different types of problems with their heart, and that can include, but are not limited to, coronary artery disease, which is blockages of the arteries, heart failure, which is a problem with the pump and pump damage, chest pain, and rhythm disturbances like electrical abnormalities of the heart. And we know that cardiac care for patients with cancer should begin at the time of diagnosis and extend well through survivorship, which is really why we're here tonight. So we know that cancer and heart disease sort of travel in a pack. I always tell my patients they're like bad cousins. They often travel together, and that's because there are shared risk factors, there's shared biology, and also one of the things we'll talk about a lot tonight is that there is cardiac toxicity from cancer therapy itself. And so we know that when patients with cancer die of something that is not the cancer itself or a reoccurrence of the cancer, they're more likely to die of diseases of the heart and cardiovascular disease. So we know that there is a very high prevalence of pre-existing cardiovascular disease in many different types of patients with cancer. So you can see in the purple here that in all different types of cancer, hematologic malignancies, lung cancer, breast cancer, colon cancer, renal cancer, head and neck cancer. The purple shows you how much cardiovascular disease in those patient populations, and it's anywhere between 20 and 30 to 40% of patients have coexistent cardiovascular disease. And so why do we worry about cardiac toxicity in cancer? Well, we do know that when you have an acute problem, like a problem that happens right away, it can affect your survival because it can affect our ability to offer you the latest and the greatest and the best cancer therapies, but we also know that chronic toxicity can affect survival, morbidity, and quality of life. So you can see here in this graph, this is actually a breast cancer study where you can see that around 8 or 9 years, patients are much less likely to die of breast cancer and more likely to die of cardiovascular disease. So we also know, and really I think the main reason why you joined tonight, that there's a growing population of cancer survivors, as Dr. Meyers pointed to. And so we know that by the year 2040, there's estimated to be almost 30 million cancer survivors. And you can see sort of the age groups, and the largest groups are patients ages 65 to 85, I would say. So this is a very large and growing population of patients that we need to be aware of. So we also know that there are many adverse cardiovascular side effects of cancer therapy, and we are not going to have time tonight to talk about all the different things that cancer therapies can cause to the heart, but suffice it to say that many different cancer treatments can cause cardiomyopathy, which is damage to the heart muscle. That's a large part of my job as a heart failure doctor. We also know that there's a lot of cancer treatments that can cause high blood pressure, ischemia, blockages in the arteries, valvular disease, or rhythm disturbances. So interestingly, for example, prostate cancer and cardiovascular risk, this was a meta-analysis that was done that looked at risk factors in patients with prostate cancer. And actually, in this particular study, they found that almost 100% of prostate cancer patients had at least one modifiable cardiovascular risk factor that was not controlled. And more than half of them had more than 3 uncontrollable risk factors like high blood pressure, diabetes, coronary artery disease, high cholesterol, things like that. And we, of course, know that men with a history of cardiovascular disease have higher rates of cardiac events from prostate cancer therapy. In breast cancer, we know that there's 2.6 million breast cancer survivors in the United States alone. We know that there are very common risk factors between the two, so between cardiovascular disease and breast cancer, a lot of things that, again, travel in the same pack. So family history, alcohol intake, hormone replacement therapy in certain situations, tobacco use, older age. We know that there can be many, many issues in patients with breast cancer who either have heart disease to start with or who develop heart disease based on the treatments that they're getting for breast cancer. So for example, 5 to 10 years after chemotherapy for breast cancer survivors who in particular have received anthracyclines, as it's a type of chemotherapy as part of their breast cancer therapy, have a lower pumping function of the heart, a lower ejection fraction compared to those who didn't receive that type of chemotherapy. And for example, if you're a person who had breast radiation therapy in the older era, like before the year 2000, we know that those patients are at increased risk of coronary artery disease because of the way they did the breast radiation back then, and it was right above the coronary arteries. So we also know, for what it's worth, that with contemporary breast cancer therapy and contemporary breast radiation, that the risk is less, but the risk is not zero. We still know that compared to the general population, even women that are getting breast cancer radiation now are going to be at somewhat of an increased risk, 10 or 20 years down the line. This is a large Medicare registry looking at cardiovascular events in a breast cancer registry. This was over 63,000 breast cancer patients. And you can see that especially with earlier stages of breast cancer, women were less likely to die of breast cancer and more likely to die of cardiovascular disease. But I found probably even more interesting than that in this study was that of the women that died of cardiovascular disease in this study, only about a quarter of them were recognized as having cardiovascular disease as a comorbid condition at the time of their breast cancer diagnosis, which really speaks to the fact that we're not looking and we're not paying attention to this stuff, and oncologists and cardiologists and patients together are just probably not as aware of this as they need to be. So the risk is especially high in older women with breast cancer. So in this, in this one study, over 45,000 older women above the age of 65 with early stage breast cancer, this was what I just showed you, more than 1 in 10 women who had specific types of chemotherapy developed a problem with the heart, including heart failure. And the risk of developing that goes up with every decade in life. And again, in the same study that I just showed you, most of the women hadn't even seen a cardiologist before or during their breast cancer treatment, which may have led to a delay in diagnosis of their heart disease. meaning, again, we're not looking early enough and we're not aggressive enough about screening for this stuff. So how do we think about all of this heart risk in patients with cancer? So really, I mean, in the field of cardio-oncology, which I should have said at the beginning, I always tell patients it's like the marriage of cardiology and oncology. We really think of it as a continuum where we identify, we mitigate, and we do surveillance. So we think about it from the time of baseline. You know, ideally, we actually get a hold of many patients at the time of their diagnosis of whatever cancer, because we like to intervene very early and we like to control for whatever risk factors we can. But then again, it's sort of a spectrum and it's a continuum during cancer therapy and then in longitudinal follow-up into survivorship. And you will see a reoccurring theme during the rest of my slides is a lot of it is about risk. So identifying who's at low risk and we can maybe watch a little less and drive a little less crazy, and who's at higher risk where we really need to do very, very careful monitoring throughout the course of their cancer journey and well into survivorship. So the American Society of Clinical Oncology published this guideline a few years ago, which really, I think, did a very nice job of asking 5 very simple questions that we sort of use as an overarching theme in how we evaluate patients, how we talk to patients, and you can see them here. So which patients with cancer are at an increased risk of developing cardiac dysfunction? What preventative strategies can we use to minimize the risk before we start treatment, during treatment, and what preferred surveillance and monitoring approaches can we use during and after treatment for patients that we determine to be at risk for developing cardiac dysfunction? So to start with the first question, which patients are at an increased risk of developing cardiac dysfunction? That sort of gets to Ben Franklin's quote, well, an ounce of prevention is worth a pound of cure. So how do we try and identify which patients are at higher risk so that we can intervene very early with preventative strategies? We have a lot of tools now. I have to say, as a side note, when I started doing cardio-oncology around 2013 or 2014, there really wasn't much to go on in the literature. There wasn't a lot of research out there, and we really didn't have a lot to hang our hat on in terms of how to identify risk in patients. Now, in 2024, we have a ton of data to suggest, you know, certain things that we should be looking at to really hone in on which patients at baseline when they're diagnosed with cancer are at low risk, medium risk, or high risk. And I'm not going to go through everything here, but suffice it to say, in those patients that we determine, and I'll go through in the next slide sort of how we do that, in those patients where we determine that the risk is moderate or very high or high risk, that helps us determine how much surveillance we do, what type of testing we do, you know, how often we need to do it, and that helps us manage risk a lot. So this is sort of one of those schemas that we have now available to us. This was published in the European Society of Cardiology, and I have to say, if I look at one document the most every day, all week long, like my whole life, it's this document, because for cardio-oncologists, this is sort of like our new Bible. This shows us exactly sort of all the different cancer treatments and what the cardiac risks are and how we determine who to follow and how aggressively to follow them. So who is at the highest risk of cardiac dysfunction? So we think about this in a couple different ways. So we think about therapy-related and patient-related risk factors. So therapy-related risk factors have to do with what cancer therapy you're getting or what cancer therapy you got. Patient-related risk factors are you male or female? Are you old or young? Do you have traditional cardiovascular risk factors like high blood pressure? Are you a smoker, a previous smoker, obesity, high cholesterol, insulin resistance, diabetes? So we think of it in sort of those two different categories. So when you think about the person who is at highest risk, it's the people that have gotten higher lifetime doses of the anthracycline chemotherapy. And if you're not sure whether you got it, you can certainly look at your records or you can talk to your oncologist. Patients that have gotten sequential chemotherapy and other cancer therapies, for example, anthracyclines and trastuzumab therapy, patients that have gotten higher doses of radiation to the chest, either in the past who are survivors of childhood cancer or people who have gotten radiation therapy. And then in terms of patient-related risk factors, females unfortunately are at higher risk. The older you are, the higher the risk you are, and the more traditional cardiac risk factors you have, the higher risk you are. And also very much depends on your medical history and some blood work that we use. So all of this sort of combines to help our frame of reference as cardiologists to determine, and to help with your oncologist to determine what your risk is, sort of going into the endeavor, during the cancer treatment, and then as survivors. In the world of heart failure, which is my other love as a heart failure cardiologist, we think of heart failure in stages, and stage A is any patient that is at risk of developing a weakening of the heart, a stiffening of the heart, or heart failure. And any patient who has gotten any cancer therapy that increases the risk of cardiac toxicity is considered stage A. And that's the reason why we take all of that very, very seriously. So there are a bunch of different cardiac assessment tools that we use. Like I mentioned to you, when I started, none of this existed. Now it exists in multiple folds. But this is one thing that I just wanted to show you, not to go through in detail, but just to show you that now we have ways to risk stratify patients. And I have to say, when I see patients in the office, I actually show them these graphs now, because I can sit with a patient and I can actually go through line by line and show a patient how I think that I'm factoring in their risk factors to tell them whether I think they're low, medium, high, or very high risk. I just wanted to show you all that in this particular document, there are several different graphs that exist for several different cancer treatments. So depending on what your oncologist and you are using for your cancer, we can then help determine risk in a more definitive way. Which preventative strategies can minimize the risk before and during your treatment? I'm not going to go through this in great detail, one, because I will bore you, but two, because we just don't have enough time to go through this. This is a lecture in and of itself. But suffice it to say, what I wanted to just say here was that we have a lot of ways to either prevent or decrease cardiovascular toxicity. And we use a lot of the literature that we have in the heart failure database, which is, again, sort of, I'm a heart failure cardiologist, so I know a lot of the heart failure literature. We know that there are certain medications that can actually decrease your risk of the heart becoming weaker or the heart becoming stiffer. And while I will say all in, there have been a ton of trials, and some show some benefit and some show no benefit, there overall has not been shown to be harm with using a lot of these medications, but this really needs to be individualized. So I don't want to go through every treatment, protocol with you, but I do want to say I think it's worth talking to a cardiologist, and if you don't have a cardiologist, asking your oncologist if you should have a cardiologist or a cardio-oncologist ideally, so that you can kind of go through the risk and benefit of starting some of these treatments. So we do know, and this is interesting new data, that statins, which are cholesterol-lowering medicines, you may know them like atorvastatin, rosuvastatin, are in general safe, and they may reduce the risk of toxicity to the heart with particularly certain types of cancer treatments like anthracyclines. I think this is an evolving field that really needs to be uncovered a little bit more, but there was a recent study that actually showed that in lymphoma patients who were on atorvastatin versus placebo, there was actually a significant risk reduction in the development of a weakening of the heart. So not to say this is for everyone, but certainly this is something that should be discussed with your cardiologist. It should be considered in all patients receiving anthracyclines, but it is very individualized and it depends on a lot of different factors. So I like this slide. This is from that same document that I showed you before, because it shows you how we think about this. So there's something called primary prevention and there's something called secondary prevention. When we say primary prevention, we mean before there's actually a problem, before there's blockage in the arteries, before there's heart failure. We know that we have opportunity to intervene. Secondary prevention is what we mean when we say a person has already had a heart attack, or a person has already had a stroke, or a person already has heart failure, and what can we do to decrease the risk that they'll have another heart attack or another stroke or another cardiovascular event. And you can see that when you juxtapose this in the world of cardio-oncology, that in patients that are high or very high risk of developing a problem or a second problem, we take very seriously our ability to intervene with a lot of these medical treatments, like I showed you on the other slide with the medications that we would normally maybe use in people with high blood pressure or with heart failure. So I think it's really, really important. Again, it's sort of a lecture in itself to talk about high blood pressure with cancer treatment and cancer itself. But I think it's really important for you guys as the audience to know that high blood pressure can affect about 30 to 40% of patients with cancer. And it often happens early in their cancer treatment, and it often can limit access to true gold standard cancer therapy, either because we have to pick something else because the high blood pressure is uncontrolled, or because there's some type of cardiac event that happens because of the high blood pressure. So I'm not going to go into the details of this, but I did want you to be aware of this because many different types of cancer treatments can cause high blood pressure. Many patients that got diagnosed with cancer or survived cancer already have high blood pressure as a diagnosis, and it's incompletely treated. And it is so important to talk to your doctor about treating your blood pressure, to be measuring your blood pressure at home, and give your doctors those readings so that we know how well or how poorly the high blood pressure is controlled, so that we can control that and give you unlimited or less limited access to the treatments that your oncologist wants to give you for your cancer, and also into survivorship. And I would be remiss if I didn't at least say a word about exercise. So I'm sure Dr. Meyers could speak to this also, but we feel very strongly in the cardiology world, and I know they feel very strongly about this in the oncology world, that exercise pre, during, and into survivorship for cancer patients is of paramount importance. There is data in both cardiology and oncology to suggest that patients that exercise regularly do better just in general in terms of their outcomes, cancer reoccurrences, cardiovascular outcomes. But I think in 2024, we're really still not entirely aware of how to do this well. We counsel patients about exercise, but I think the pie in the sky dream for us is to be able to actually give an exercise prescription the same way we give a prescription for a blood pressure medicine, to individualize this to individual patients, to individual types of cancer treatments, to survivorship versus active cancer treatment. But exercise is really, really, really important. So you shouldn't stop. You should keep doing it as much as possible. And you should talk to your oncologist and your cardiologist about how to do it and what to do. So what about during and after treatment? So we obviously need to talk about surveillance. So I want to just show you strain echocardiograms. An echocardiogram is basically an ultrasound picture of the heart. It shows us the pumping function of the heart. It shows us the valves, shows us if all the walls of the heart are coming in. Strain echo is something that we use very regularly in patients with cancer and survivors of cancer, because I always tell patients in the office, it's like if you take your car to the mechanic doesn't look at the car and say, oh, everything's fine, come back in a year. The mechanic opens the hood of the car and looks at all the nooks and crannies under the hood to tell you if there's something hidden that you may not see by just looking at the car as a whole. So that's what strain echo does. And, without going into too much detail, it gives us a deeper dive and a deeper look to tell us if something might be brewing, even if on first pass the heart looks okay. The other thing that we use more frequently, maybe in patients with cancer and survivors of cancer, is three-dimensional echocardiogram. And that's another way of looking at the ventricle, which is the main pumping chambers of the heart, in a three-dimensional image rather than two-dimensional, and it also gives us a better sense of exactly what's going on with the heart. So you may find that when you go for echocardiograms during or after your treatment, that your doctor is ordering a special kind of echo, and that's the reason why. It gives us just more information. So when it comes to surveillance, you might be asking, how do we possibly know what to do for surveillance, what type of surveillance to do, and how often to do it? And this, again, kind of gets back to two things. It gets back to patient risk, and it gets back to therapy risk. So you can see here on the right, without going into too much detail, all the different kinds of cancer treatments that might predispose a person to problems with the heart, but it also then breaks down what we should do based on risk. So a person who's very low risk, maybe younger, no cardiovascular risk factors, maybe a cancer treatment that is not as risky for the heart, is not going to need the same type of surveillance and testing and watching as a person who is older, who has diabetes and high blood pressure and maybe already had heart failure. So obviously we want to tailor the therapy that we're giving you and the surveillance that we're doing based on risk. And this I just wanted to show you very quickly, this is sort of something that we look at for breast cancer patients specifically. Again, based on what type of breast cancer therapy you're getting and whether your baseline during or after your therapy. But a lot of this is not a one-size-fits-all. It really has to do with your individual risk profile, which is why I think it's so important for patients with cancer who are at any type of risk be seen by a general cardiologist or if possible, a cardio-oncologist. I didn't want to go through the details. I just want to show you that this is also from the same paper, and you'll see a common theme throughout, that the surveillance and how often we do it and what type of testing we do very much depends on the risk. So low risk versus high and very high risk. So what's the purpose of all of this cardiac surveillance? Why it might seem like we're driving you crazy by doing this, but why do we do it all? So time is of the essence when it comes to this, and this is where sort of I put on my heart failure cardiologist hat. I want to show you just this quick study. This is 200 cancer patients that did not have any symptoms whatsoever, and all of them got an echocardiogram to look at the pumping function of the heart, and they included patients that had a pumping function that was below normal. So normal is 65%, and these 201 patients with cancer had an ejection fraction of 45% or less. So they didn't have any symptoms, but they had a problem with the pumping function of the heart. And what they did was the people that ran this study separated into people that were responders, partial responders, and non-responders, meaning that when they started therapy, these two medications, enalapril and carvedilol, which we use very heavily in our heart failure population and sometimes in patients with cancer who need it, what they did was they wanted to see whose pumping function got better, whose didn't respond, and whose partially responded. So to cut to the chase here, what they found was that in patients where you identified that there was an issue with the heart and you started therapy specific for the pumping function of the heart, within the first 6 months, those were the patients that were more likely to be responders. But if you waited too long to diagnose and treat those patients, the ejection fraction didn't budge or it got worse. So the point is that early time to diagnosis and therapy is the key to success here. And this is sort of a principle, again, as a heart failure cardiologist, I know this, and this is how I treat my heart failure patients, but we extrapolate this with patients that have cancer or patients that have survived cancer, because it's really important to diagnose early and treat early for the best outcomes. So the other thing that's really important, and again, without going into too much detail, and an oncologist I'm sure would tell you the same thing, is that when you have to discontinue cancer treatment early, it absolutely affects mortality. And that's the reason why we as cardio-oncologists want to do everything we can to diagnose and treat and do surveillance early so that we can call up the oncologist and not tell the oncologist, I'm sorry, but I think that you need to stop what you're doing because there's a problem with the heart. But instead, the phone call that we can make is, I'm going to try and treat through this, and I'm going to try and be really aggressive about modifying the risk and modifying the cardiac issues so that this patient can actually continue their cancer therapy and live well into survivorship. So this is another slide to show that overall survivor in patients with cancer is less if there are delays in delivering chemotherapy or other types of cancer therapy, which is why we really try our best to avoid this. So there's this concept that has really kind of taken shape in cardio-oncology, which I think about a lot, and I talk to oncologists and patients about a lot, which is this thing called permissive cardiac toxicity, which is exactly what I was just talking to you about in the last slide, which is that sometimes, depending on the situation, if we are monitoring and we pick something up early and patients especially don't have symptoms, but we know that there's a problem, that we can oftentimes treat through it, and we don't necessarily have to stop your cancer treatment or adjust what we're doing, but actually allow the cancer treatment to proceed, but still be very aggressive about modifying the cardiac toxicity. And that's what we call permissive cardiac toxicity. So now what you're really here for, which is to talk about survivorship. So I have a few slides to talk about childhood cancer survivors and adult survivors of cancer. So just some statistics on childhood cancer survivors. We know that patients who are children when they receive cancer treatment are 15-fold increased risk of heart failure and a 7-fold increased risk of premature death from cardiovascular causes compared to the general population. And the highest risk is in those who received radiation therapy to their chest. Nearly 60% of childhood cancer survivors have had a history of either anthracycline chemotherapy or radiation therapy to the chest. And we also know the problem is that there's a long period of time between when these kids were treated and then into adulthood when they actually present after their cardiac exposures. So there are several guidelines that exist, but many of them differ, and I'm not going to go into the details of it, but suffice it to say, this is a population that I think is under-recognized, under-treated, and really, really important for us to talk about. So the traditional cardiovascular risk factors, like we talk about always, high blood pressure, smoking, high cholesterol, all of these things are multiplicative in patients that have survived childhood cancer. Meaning that if you have high blood pressure as a regular adult who didn't have cancer treatment as a child, you have a high risk of developing heart failure, a stroke, a heart attack. But if you have high blood pressure as an adult, even as a young adult, and you had radiation to your chest or you had cancer therapy as a kid, specifically anthracycline therapy, you are at a multiplicative risk of developing these adverse side effects like heart failure, heart attack, stroke. So it's really, really important that we control for risk factors. It's really critical. So this is actually a very dear patient of mine. I'm actually going to see her tomorrow in the clinic. I've been following her for, I don't know, 5 or 10 years now. She came with me to NYU. She's a 43-year-old Caucasian woman. She has a history of Hodgkin's lymphoma at the age of 16. She had a chemotherapy regimen called ABVD-MOP. We didn't know at the time when I met her what her dosing was of her chemotherapy, but we do know that she had an extensive amount of radiation to her chest. And she had an outside echo done by an outside cardiologist before she met me several years ago, where she had moderate aortic stenosis and a heavily calcified aortic valve. That's basically a fancy way of saying there was a lot of calcium on the main valve where the blood leaves the heart and goes to the rest of the body. That's your aortic valve. But she had a normal pumping function of the heart, and all the walls of the heart were coming in. And so if you go into a regular cardiologist's office and you want to know what your risk is, a lot of cardiologists use this thing called an ASCVD risk estimator. And that's basically a fancy way of plugging in your age, whether you're female or male, whether you're white, African American, or other, and you plug in all these factors like your blood pressure and your cholesterol, whether you're a smoker, whether you're diabetic, and all of this to say it spits out a number and it tells you what your 10-year cardiovascular risk is. Many of you, I mean, if you wanted to, you could do this online for yourself. And in the case of this patient, we did it in the office, and the risk that we got for 10-year cardiovascular adverse outcome was 1.2%. So what I will argue to you is that patients that are childhood survivors of cancer, they are not going to fit into any conventional risk estimator that exists right now, because those risk estimators do not take into account what they got as children and what their increased risk is. And by the way, you can make this argument also for really any patient who is a survivor of any type of potentially cardiotoxic cancer therapy, because you'll notice that in that other risk calculator that I showed you, none of this exists. So when we plugged her risk profile into this other risk calculator called the Childhood Cancer Survivor Study, what you can see here is that actually when we plugged in what cancer treatment she got and the radiation therapy, you can see that her risk was high for heart failure, for ischemic heart disease, which is blockages in the arteries, and for the likelihood that she would develop a stroke. So significantly different. Same patient, same day, different risk calculators. So what happened with this patient? So this is her cardiac cath report, and suffice it to say she had severe coronary artery disease in all 3 of her main vessels. She wound up actually having to have a bypass surgery to 3 of her vessels. She had 2 valves that had to be replaced. And this was all because of her cancer therapy when she was a child and the radiation therapy specifically. By the way, I should say when I met her, she had no symptoms at all. And within 1 or 2 years, she developed some mild shortness of breath. And that's what prompted us to do all of the testing. And that's what we found. So this is just a quick slide to show you that there are surveillance guidelines that we use for childhood cancer survivors. And they are based on how much chemotherapy, what dose of chemotherapy you got, and how much radiation therapy you got. And we use these as a general sort of marker for how often and what type of testing to do for these patients. But I will tell you that these patients present earlier than a normal cardiac patient would. So in their 20s, 30s, 40s, 50s, rather than sort of in the later decades of life that we see with our typical cardiac patients. I think we're sort of getting toward the end, but so just in summary, you may be at risk if you've had treatment for cancer in the past, if you're a childhood survivor of cancer, if you've had a previous history of receiving certain types of chemotherapy, and particularly if you've had radiation to the whole body or the chest or the breast, especially many years ago. You may also be at risk if your medical history includes older age, diabetes, high blood pressure, high cholesterol, or a family history of cardiovascular disease, heart attacks, sudden cardiac death in your family. Next slide. Preventing heart disease in cancer patients is gaining more importance as aggressive cancer therapies are getting better, patients are getting older, and research is identifying a growing number of cardiovascular side effects in a lot of the cancer therapies. So honestly, cancer therapy is evolving in such a rapid way, but with that, we're discovering a lot more issues with the heart that we really need to be aware of, and we need to be careful about looking for this stuff and aggressively treating it. So early diagnosis is important. Hopefully I've convinced you of that. Studies show that the earlier the detection of the cardiac issues before symptoms occur can lead to a higher likelihood of being able to continue your cancer treatment and just overall better survival. So in conclusion, survivors of both childhood and adulthood cancer are at an increased risk of developing cardiovascular disease at a younger age than their non-cancer counterparts. There is no safe dose of anthracyclines or radiation therapy to the chest. Your risk is definitely increased with age or other cardiac risk factors like high blood pressure or high cholesterol. Traditional cardiac risk factors are compounded in patients that are childhood survivors of cancer. And the survival after the onset of heart failure is much more poor than if we aggressively screen and we treat, like I showed you with that study where in patients without symptoms, if you treated early, they had a better chance of recovery of the heart. Cancer survivors definitely need personalized and a risk-based care and surveillance plan. So it's really, really important to talk to your doctors about this. And awareness and early referral is really the key to better outcomes. So speak to your oncologist about whether you should see a cardiologist as part of your cancer treatment plan, or certainly if you're a survivor of cancer, you can call to schedule an appointment. If you want to learn more about our program, you can reach out to us directly. You can find me on the website. You can find Dr. Meyers on the website. And I just put in here as the last slide, there are also resources for patients. So one of our governing bodies in cardio-oncology is called the International Cardio-Oncology Society. And if you type in ICOS or International Cardio-Oncology Society resources for patients online, there are a ton of different articles and ways that you can click through to get more information on these subjects. But certainly if you have any questions, I would really highly encourage you to talk to your doctors about it. I put this at the end. It's a man at the pharmacy and he says, I'll have an ounce of prevention. So hopefully I've convinced you that an ounce of prevention is worth a pound of cure. And so we should really try our best to prevent all of this stuff so that we don't have to talk about disease. So, I mean, I think a lot of it depends on what specifically they gave you. So many of the conditioning regimens contain agents that can potentially be toxic to the heart. And we also know that patients that have undergone stem cell transplants, bone marrow transplants, are also at an increased risk of cardiovascular disease for multiple other reasons. So I would say just in general to that listener that they should talk to their oncologist and maybe a cardiologist to try and identify, whether they're low, medium, or high risk. It's hard to say without knowing the specifics of what they got, but I would say in general, those are patients that we very often see, yes. So the immune checkpoint inhibitors, I will say, and I think most oncologists would agree with me, they have changed the landscape of cancer care. They have basically changed a lot of these cancers from a time of diagnosis, very high mortality, to patients are living years and years beyond their predicted survival. And they are very powerful drugs. But what they do is they sort of trick the immune system into killing tumor cells. But the problem is that they're non-specific. So in doing so, what they can also do is they can cause other systemic immune reactions to multiple different organs, including the thyroid, including the kidney, including the lung, and of course, in my line of work, including the heart. And so there are rare side effects to the heart, but the problem is, even though they are rare, we're seeing them more and more, especially in patients that are on immune checkpoint inhibitors for longer amounts of times, and especially in patients that are on combination immune checkpoint inhibitors. In other words, instead of being on one, maybe you're on two at the same time. And the problem is, even though they are rare, if you have an immune checkpoint, we call it myocarditis, it's like an inflammation of the heart, it can be fatal if we don't find it and treat it aggressively. And I have a number of patients I'm treating for it. And I will say, as rare as it's reported in the literature, maybe I'm biased because I see these patients day in and day out, but we are seeing a lot more of it. And it can fool oncologists and it can fool cardiologists because patients may not necessarily present with symptoms that are obvious for it. They can be non-specific symptoms. So it's just something to be aware of and talk to your oncologist about if you have any concerns whatsoever. I think that we could talk about diet for a whole hour, but the fact of the matter is that I don't think that there's a one-size-fits-all, and I am not one of those cardiologists that in the office is like an all or none kind of person, because I think that there are many different factors that go into a patient's diet, and culturally and ethnically and you know, history-wise with your diet. But I will say in general, there are many people in cardiology and maybe in oncology as well that advocate to practice as much of a plant-based diet as you can. And by that, it means like whatever grows from the ground and is not processed, to avoid processed food, avoid anything that has you know, extra ingredients that are not natural, because there is a very large body of research now that shows that anything that you add, you know, that makes foods processed and things like that can add to inflammation in your body. And we know that when we talk about common risk factors between cancer and cardiovascular disease, that an inflammatory state, sort of like a pro-inflammation systemically in your body, can lead to adverse outcomes and may be the reason why there's such a high link between cancer and heart disease. So the more of a plant-based approach you can have to your diet, probably the better. And so generally that's what I tell people to try and do. But I don't know that I believe that there's a one-size-fits-all diet. Obviously, avoiding red meat as much as possible, avoiding things that have, you know, high saturated fats, anything with added salt or sugar, anything that is heavily processed is probably something that you should be staying away from entirely, and everything else should be in modified amounts. But the more plant-based you can be, probably the better. Not specifically necessarily, and I would be remiss if I told you that I knew specifically the literature on risk to the abdomen and like the vascular structures behind the pancreas. But in theory, the pancreas is sort of in the same area as a lot of the other vessels. Like it's not on top of the heart, but in theory, it could potentially affect the vessels behind the pancreas because you know, there's a lot of vessels that sort of travel in that abdominal area. So it may be something to ask your oncologist about, especially if they think that you're higher risk, but it is not traditionally something that we would put as part of our risk models for the heart. Not to give you sort of a wishy-washy answer, but it really does depend. So traditionally, in patients that have a problem with the pumping function of the muscle of the heart, with just Herceptin or trastuzumab therapy, it was classically thought of that that was reversible. And even if you didn't do anything, it would reverse. I would actually argue, and maybe, you know, this is my bias because I'm seeing a lot of these patients where it's not reversible, that we should still be aggressively treating these women with breast cancer who have had trastuzumab toxicity. A, because we then decrease the chance that they have to come off of their therapy and they can stay on their therapy like I showed you in those slides. But B, because there are situations where it is not reversible. And so sort of in the world of heart dysfunction, we tend to be very aggressive about treating. We can always pull back treatment later if we feel like the heart has completely recovered and under certain circumstances, we don't think it's necessary to continue it. But it's a lot harder to be wrong and look and say, you know what, I should have treated that woman aggressively for the you know, the heart dysfunction because I was wrong and it wasn't reversible, because then you've lost the you know, the golden hour, as they say. So I would actually argue that, even if the likelihood is that certain times it will be reversible, you should still be under the watchful eye and the treatment of a cardiologist. I hope that answers the question. I think a lot of these questions, it's hard to answer specifically because there's so much that goes into these answers and these decisions. With my patients that I follow that have ovarian cancer, metastatic ovarian cancer, a lot of the issues with the heart have to do with the therapies that they're getting for the metastatic cancer, less so than the surgeries that they're getting, because a lot of the therapies that they get can be directly toxic or indirectly toxic to the heart. And also remember that women that have ovarian cancer tend to be older, so maybe they also have other cardiovascular risk factors like high blood pressure, diabetes, maybe they were smokers, whatever other risk they sort of bring into the diagnosis of the ovarian cancer. So maybe those women are at a higher risk anyway. So it's not so much about the surgeries as it is about what cancer therapies they're getting and what their risk factor profile was and is during and following treatment.